Hello everyone, my name is Kareem Seivwright and today I'll be presenting on a literature review, diagnosis and treatment planning article 3. For the article information, the article title is Eating Disorders and Oral Health, a matched case control study. The authors are Anne Katrin Johansson, Claes Noring, Lennart Unell, and Anders Johansson. The name of the journal is European Journal of Oral Sciences. The journal impact factor was found to have an H index of 88. The date of publication is October 2011, and the type of article is a case control study. The major topic is eating disorders and oral health as it relates to adolescents and adults. The major purpose: the aim was to compare the oral health status of patients with eating disorders and sex and age-matched controls with a view to identify self-reported and clinical parameters that might alert the dental healthcare professionals to the possibility of EDs. Eating disorders are linked to a variety of behaviors stemming from singly or in combination, which can possibly influence both general health and oral health. EDs are divided into three main diagnoses. Anorexia nervosa, known as AN, is characterized by underweight and food restriction. Bulimia nervosa is characterized by binge eating, known as BE, in the study, and inappropriate compensatory behaviors like self-induced vomiting, VOM, the use of laxatives, and excessive exercise. Eating disorders not otherwise specified, known as ENDOs in the study, is not clearly defined but may be linked to heterogeneous mix of AN and BN like typical eating disorders. The same patient may have had varying ED diagnoses in combination with more healthy or less healthy periods during life. Early detection of EDs is crucial in the outcome of the disease with respect to psychological and somatic complications and its oral health consequences. The duty of the dentist is paramount and must be knowledgeable. An informed dental professional is needed to aid with the secondary prevention of EDs. EDs patients tend to avoid healthcare professionals, and even if they do visit, they often hide the true nature of their problem, which can be linked to guilt, shame, and self-denial of the disease. In ensuring patients from the control arm of the study were not actually EDS patients, the symptom index of the eating disorder inventory 2 EDI 2 was used to exclude them. The EDS patients had several signs, example dry cracked lips, parotid gland enlargement, esophagitis, which indicated a negative effect on the salivary glands, possibly caused by frequent vomiting or starvation, which caused hyposalivation. Dental erosion is regarded by most as a common sign of EDS. Dental caries was not found to be significant between the EDS group and the control group. The visible plaque index, known as VPI, and gingival bleeding index were significantly lower in the EDS group. This is most likely attributed to EDS patients having obsessive compulsive behaviors such as intense and frequent toothbrushing. Based on the results of the present day study, the dental team should look out for symptoms and signs such as present dental problems, burning mouth, dry cracked lips, good oral hygiene, and dental erosion, which could be indicative of a patient with an ED. From the article, here's a graph which shows self-perceived oral health in 54 eating disorder patients and 54 sex and age-matched controls. Here we can see from good to rather good that the controls had a higher response rate compared to the eating disorder patients. But from not so good, you can clearly see that the eating disorder patients definitely had a higher response rate in terms of their perceived oral health. It was almost equal in bad, but with the ED patients still being a bit higher, and in very bad, there was only ED patients responding. Table 1 from the study shows a percentage distribution of self-reported symptoms among 54 ED patients and the 54 sex and age match controls. Here we have a range of oral symptoms and problems, from tooth sensitivity or pain for cold drinks to mouth dryness, burning tongue, tongue thrusting during the day and night, as well as nausea, facial pain, and a lump in the throat. Here we have the responses from ED and controls. It was shown that the most significant ones were mouth dryness and burning tongue, including tongue thrusting at night, as well as facial pain and a lump in the throat, which was most significant for the eating disorder patients as opposed to the controls. In Table 2, it shows percentage distribution of clinical findings relating to intraoral and extraoral soft tissue and salivary parameters in 54 ED patients and in 54 controls. Here we can see the soft tissue findings, the salivary parameters, and it is clearly shown that most of them were not significant, except for the dry and cracked lips and the parotid gland swelling, which was mostly significant for the ED patients. For Table 3, dental problems in 54 ED patients and in 54 controls, we can see the visible plaque index, the gingival bleeding index, the DMFT and the DMFS, as well as cervical defects and dental erosion on a mean. As was stated before, the VPI and the GBI would not be significant in the eating disorder patients, and even though this would seem very confusing, it was already stated that it would most likely be attributed to the severe psychological effect from the disease, causing obsessive compulsive disorders to brush the teeth constantly despite the bad eating habits. Henceforth, VPI and GPI would be low. DMFT and DMFS, there was not much of a clear significance between the two. Effects of eating disorders. Here we see dental erosion in two images caused by acidic attack. In the case of an ED patient, this can be mainly due to forced vomiting, leading to frequent acidic exposure of the teeth, especially on the lingual surfaces as seen in the picture. This image shows a child with severe dry lips and angular cheilitis, which in this case, the cause of this for an ED patient would be starvation leading to hyposalivation. Here we see a patient suffering with parotid gland enlargement, which is another common finding in ED patients and is due to constant vomiting or starvation. And we have globus sensation, which is another manifestation of eating disorders. It is characterized by difficulty in swallowing, and it is said to be as if there's a lump in the throat, even if one is not physically present. It appears more frequently in women and is associated with depression as well as gastric reflux. For the assessment level of the article in terms of the level of evidence, based on the hierarchy of evidence pyramid, the level of evidence within this study is of level 2. This is due to the study being a case-controlled study, and it would provide better validity of the results within the study since two groups were being compared, even though they were not randomized like in a randomized clinical trial, which is of the highest level of evidence. The study showed a reduction in bias of the results by utilizing the symptom index of eating disorder inventory 2, which was used to exclude eating disorder patients from the controls. A questionnaire was constructed in collaboration with personnel at the eating disorder clinic with the aim of detecting and evaluating possible factors affecting oral health status. There was also blinding of the dental examiners, ensuring they did not know of the medical history of results and the questionnaire for both ED patients and controls, which I found to be very good in an attempt to make the results more valid. Assessment of article conclusion. If a dentist is well versed in identifying the self-reported symptoms and clinical signs of a patient with ED, then early diagnosis can be done, thus resulting in a better outcome for ED patients. This will promote decreased psychiatric, somatic, and oral deterioration caused by the disease. These are my references. And if there are any questions, this is the end of my presentation. Thank you.